Hi guys, so today we're gonna continue talking about the musculoskeletal system. This is gonna be, I think, part 3 now. So today I want to talk to you guys about the examination of the knee and the examination of the foot and the ankle. Just bear with me because there's no electricity in the flat. So I am using my mobile hotspot for the call. So this might actually cut off, but I'm actually recording on my phone as well. So you guys can watch this at a later date in case the connection just cuts off. So okay, firstly, let's talk about the knee. So let's review some of the basic anatomy. So the knee is the largest joint in the body. And the knee joint actually involves 3 bones. So we have the femur, we have the tibia, and we have the patella. The knee is an example of a hinge joint, which is a type of synovial joint. And recall that synovial joints, they have the articular cartilage that covers the end of the bones. So in the knee, we call the articular cartilage around the femur as the condyles of the femur. And the condyles of the femur, they kind of sit on top of the tibial plateau. There are many supporting structures in the knee joint. So we have the menisci, we have the ligaments, and we have the tendons. So let's start with the menisci. So menisci is just plural for meniscus. So in each knee, we have 2 menisci. So we have the medial and the lateral menisci. So the medial is obviously on the medial side and the lateral menisci is on the lateral side. So we have medial lateral menisci on each knee. So the meniscus or the menisci, they basically act as cushion for the femur. So they help with the weight and the force distribution. So basically what they do is they cushion the femur and they spread the force and the weight over a much larger surface area. So it's not concentrated in one small area. So that's how it helps with the cushioning and the lessening of the impact within the knee joint. It also helps with stability because of its shape. So if you look at the if you look at a diagram of a knee, the meniscus, because of its shape, it's thicker on the outside and much thinner on the inside. So it acts like a wedge. So because of its shape, it's thicker on the outside and thinner on the inside, and this is the femur. So it stops the femur from rolling over and off of the tibia. So the tibia is down here and the meniscus is here and then the femur is here. So because of its wedge-like shape, it kind of prevents the femur from rolling off of the tibia. So that's how it helps with stability. The majority of the support, however, comes from the ligaments of the knee. So we have 4 ligaments in total in each knee. So we have the ACL, the PCL, the MCL, and the LCL. So let's start with the ACL. So the ACL is called the anterior cruciate ligament. So the anterior cruciate ligament prevents the tibia from moving too far anteriorly, too far forwards. So this is how I remember it. ACL, anterior cruciate ligament, prevents the tibia from rolling or moving too far anteriorly, too far forwards. The PCL does the complete opposite. So the PCL, or the posterior cruciate ligament, prevents the tibia from moving too far posteriorly or too far backwards. So the ACL and the PCL, they're actually located within the knee itself. So within the knee joint itself, so they are non-palpable. But just to review, they provide the anterior-posterior stability of the knee. So both of them prevent the tibia from rolling too far forwards and too far back. And it's called cruciate ligaments because they actually form like a cross. The next 2 ligaments are the MCL and the LCL. So the MCL stands for medial collateral ligament and the LCL stands for lateral collateral ligament. So collateral, it just means to the side. It just pertains to the lateral aspect. So the medial collateral ligament is on the medial side of the knee and the lateral collateral ligament is on the lateral aspect of the knee. So these 2 ligaments, what they do is they like prevent the knee joint from rocking side to side excessively. So they provide like lateral and medial support to the knee joint. The last supporting structures of the knee are the tendons. So recall that tendons attach muscles to bones. So we have two main tendons in the knee. So we have the quadriceps tendon. So the quadriceps tendon attach the quadriceps to the patella. And this tendon kind of like continues across the patella and blends into the patellar tendon, which attaches the patella to the tibia. Now let's move on to the muscles of the knee. So we have two main ones. So we have the quadriceps femoris and we have the hamstrings. So the quads, they kind of cover the anterior, the medial, and the lateral aspect of the thigh. And when the quads contract, they extend the knee, okay? So the quads are responsible for the knee joint extension. And then the hamstrings are located on the posterior aspect of the thigh. And when the hamstrings contract, it flexes the knee. So the hamstrings is responsible for the flexion of the knee joint. So now let's talk about the examination of the knee. So we need to keep in mind during the examination of the knee that we must examine the 7 main supporting structures of the knee. So again, those are the medial and the lateral menisci, the ACL, the PCL, the MCL, and the LCL, and the patellar tendon, okay? So we need to examine these 7 structures of the knee. But again, let's first start with inspection. So for inspection, we have to first inspect the patient's gait. So we did this with the hips as well. So recall that a normal gait has to have a smooth, continuous rhythmic flow, and the knee should be flexed the whole time during the stance and the swing phase. It's only extended at heel strike, so when the heel actually touches the floor or the ground. After the careful examination of the patient's gait as they are walking, we need to ask the patient to lie supine with their knees slightly flexed. So we continue with our inspection. So when the patient is lying supine with knees slightly flexed, we need to inspect the knees. We need to look for any deformities, any misalignment in the knees. We note down if there's loss in the normal hollows around the patella, if there's any swelling around the patella, and if there is like atrophy of the quadriceps muscles. Now we can move on to palpation. So recall that the patient's knee is flexed at this point, well, slightly flexed as we are doing the inspection. Now we need to ask the patient to extend the knee, and we feel for the suprapatellar pouch on either side of the quads, noting for any tenderness. And then again, we ask the patient, to flex the knee, and we palpate the soft tissue depressions on either side of the patellar tendon. Again, noting for any swelling or tenderness. Also, as we press down, we can feel the edge of the tibial plateau, and we need to note if we feel any abnormal bony ridges. Okay, and as we're there anyway, we could feel the Tibiofemoral joint as well. And then after that, we need to palpate for the medial, and the lateral menisci. After that, we need to assess the different joint compartments. So we have the medial joint compartment, the lateral joint compartment, and the patellofemoral joint compartment. So again, we ask the patient to flex the knee at 90 degrees. This is not 90, but I just want to show you. So let's start with the medial joint compartment. So you palpate for the medial condyle of the femur and the medial tibial plateau, and you try identify the medial collateral ligament. And then move on to the lateral joint compartment. So you palpate for the lateral condyle of the femur, the lateral tibial plateau, and identify or palpate the lateral collateral ligament. And then moving on to the patellofemoral joint compartment. You try, identify, and locate where the patella is. So for me, it's here. And then you palpate distally to the patellar tendon, and then palpate the tibial plateau. Obviously, you note for any swelling, tenderness in these areas. And then to test if the patellar tendon is working properly, you ask the patient to extend the knee. So I actually have problems with my knee, so this is gonna hurt. Okay, so I've fully extended my knee. So once the knee is fully extended, what you can do is to compress the patella against the femur, and you can gently move it medially and laterally. It moves, trust me, the patella. It's kind of weird. So while you're doing these maneuvers, note for any pain, tenderness, and any crepitus. So there are some specific palpation tests if you suspect effusion in the knee. So I'm gonna try to show you a couple. So the first one is called the Bulge Test, and this is only for minor effusions. So let me just show you. So what you have to do is you have to ask the patient to lie in a supine position with their knee fully extended. So this is my knee. So this is the medial aspect of my knee and the lateral aspect of my knee, the superior aspect and the inferior aspect, okay? So what you have to do is to place one hand kind of on the top of the knee, and you need to apply pressure inferiorly. So I'm applying downwards pressure in attempt to displace the fluid downwards. And then on the medial aspect of my knee, I stroke it downwards and kind of laterally, okay? So this is the medial aspect, so I stroke it downwards and laterally to displace any fluid from the medial side to the lateral side. So this is what I'm doing. So I'm applying inferior pressure, and then on the medial side, I'm applying, again, inferior and lateral pressure. And then what I do is I tap the knee. So I tap the knee from the lateral margin of the patella. And the positive test is an effusion or a fluid collection, a fluid wave, or like a fluid bulge on the medial side of the knee, okay? So this next one is for major effusions. So I'm not sure what it's called. I think it's called the Patellar Tap Test. So I'm just gonna show you. So again, you ask the patient to lie supine with their knee fully extended. So here's my knee again. This is actually my bad knee, but I don't have any effusion, so you won't see the positive test here. So for the Patellar Tap Test, what you need to do is to, with one hand, you push down. So I'm pressing down, and I'm pressing down from the top, and with the other hand, you press up, okay? So what this does is it concentrates the fluid in the middle. And then with one finger, I don't know if you can see, with one finger, I press on the patella and feel whether it's floating. And obviously, if it feels like it's floating, then that means there's fluid collection in there. So this is a positive test for effusion. After palpation, we need to assess the range of motion of the knee. So there are 4 movements. So we have extension, flexion, internal, and external rotation. So what you have to do is you have to ask the patient to sit like on the edge of an examination bed with their legs kind of just dangling down. So let me just show you. Right, I'll move you guys further so you can see what I'm doing. Let's start with flexion and extension. I'm gonna do this on my right knee because my left knee is the bad knee. So just watch for my right knee. So for extension, what you have to do is ask the patient to just straighten their leg at the knee. So just do this, okay? So this is extension. Straighten the leg, okay? And to test for flexion, you need to ask the patient to bend the leg at the knee. So that's flexion. Again, extension, flexion. So to assess for internal and external rotation, so let's start with internal rotation. What you have to do is ask the patient to rotate their lower leg towards the midline of the body. So this is internal rotation. So all I'm doing is I'm rotating my lower leg towards the midline of my body. And for external rotation, it's the opposite. So you need to ask the patient to rotate their lower leg away from the midline of the body. So this is knee, external rotation of the knee. Okay? So those are the things that we need to assess for the range of movement of the knee. So we also have some special maneuvers to test the stability of the ligaments of the knee. So I'm just going to show you a couple of those. So we need to test for the stability of the MCL, the LCL, the PCL, and the ACL. So I quickly came to the realization that I wouldn't be able to do these maneuvers to myself because it's just impossible. So I'm just going to try to describe them to the best of my ability. Right, so, okay, it disconnected. Okay, right, I'm just gonna keep going. So for MCL, we do the valgus stress test. So recall that the MCL is here, right? Okay, so what you need to first do is ask the patient to lie supine with the knee slightly flexed. Obviously, this is not going to be very accurate because I'm not lying supine, and as I said, I can't do these maneuvers to myself, but I'm just going to try explain this to the best that I can. So patients lying supine with the knee slightly flexed, we first test for the MCL stability. So this is called the valgus stress test. So what you need to do, MCL is here, is to place, okay, so it's back on connection. So, right, valgus stress test for the MCL stability. So recall that the MCL is here. So what I have to do is when the patient is lying supine, knee slightly flexed, I have to put one hand on the lateral aspect of the knee and one hand grasping the ankle on the medial side. So the first hand, what I have to do is to push medially towards the midline, and with the other hand, I have to pull towards the lateral side, okay? So that's the valgus stress test for the MCL. And then for the LCL, it's called the varus stress test. So recall that, do it on the other. So this is the LCL, because the lateral collateral ligament. So what I have to do, again, patient is lying supine. Oh, that really hurt my knee. Right, so patient is lying supine with knee slightly flexed. So what I have to do is to put one hand on the medial aspect of the knee and the other hand on grasp the lateral side of the ankle. And what I have to do is with this first hand, I have to push to the lateral side, and with this hand, I have to pull to the medial side. So that's the varus stress test for the LCL. For the ACL and the PCL, we have the drawer sign. So for the ACL, we have the anterior drawer sign. So again, I won't be able to do this on myself, but I'll just try explain to the best that I can. So the anterior drawer sign to test the stability of the ACL. What you have to do is to lie the patient supine, hips and knees flex at 90 degrees. What you do is you cup the knee, so the thumb ends on, well, the thumb is resting on the medial and the lateral joint line. And what you do is you try pull the tibia forwards. Try move the tibia anteriorly. And you compare that degree of forward movement with the other knee. So if someone has torn their ACL, that degree of forward movement on the injured knee would be much greater than that of the forward movement of the tibia compared to the normal or the other healthy knee, unless they've torn both of their ACLs, which is very unfortunate. So that's gonna be the positive sign for the anterior drawer test, so the ACL stability. So for the PCL, or the posterior cruciate ligament, we have the posterior drawer test. So what we need to do is lie the patient supine with their hips and knees flexed at 90 degrees. Again, we cup the knee with our fingers. Our thumbs ending up on their medial and lateral joint line. And what we do is we push the tibia backwards or posteriorly. And again, we observe that degree of backward movement, and we compare that with the degree of backward movement of the tibia on the other knee. So the positive test is that degree of backward movement would be greater on the the injured knee. Again, unless they've torn both of their PCLs, which is again very unfortunate and very rare, I think, to injure both of them at the same time. Moving on to the ankles and the feet, which are the last parts that we need to be able to examine in the musculoskeletal system. So let's firstly talk about the anatomy. Let's just breeze through this real quick. I promise you it's going to be really easy. So the ankle joint is actually a hinge joint formed by 3 bones. So we have the tibia, the fibula, and the talus. And in terms of articulations, we have a couple of joints in there. So we have the tibio-talar joint, which is the articulation between the tibia and the talus. We have the subtalar joint, which is also called the talocalcaneal joint, because it's the articulation between the talus and the calcaneus, or the heel bone. And with the toes, we have a couple of joints there as well. Let's see if I can show you. Right, so we have, oh god, this is hurting me. We have the Mtp joints, or the metatarsophalangeal joints. So they actually form the balls of the feet. We also have, again, the PIP, the proximal interphalangeal joints, and the DIP, or the distal interphalangeal joints. Also, we have a couple of bony landmarks in the ankles and the feet. Show you again. So we have the medial malleolus, or the inside bit of the ankle. So this is a bony prominence at the end of the tibia. We have the lateral malleolus, or it's the bony prominence at the end of the distal end of the fibula. We also have the heel bone, or the calcaneus. So for the examination of the ankles and the feet, we need to have the patient lying supine, and we have to inspect the overall surface of the ankles and the feet, noting for any swelling, any deformities, any abnormal nodules, any calluses, and then we move on to palpation. So with palpation, you're not gonna see this. I'm just gonna name the things we need to palpate. So we palpate every single aspect of the ankle joint. We palpate the Achilles tendon, and then we palpate the medial and the lateral malleolus. We palpate the calcaneus, or the heel bone. We palpate the plantar fascia of the foot. We palpate the heads of each metatarsal and the grooves between them. And then we squeeze the Mtp joints between our thumb and our fingers. After palpation, we need to assess the range of motion. So we have 4 again. So we have plantar flexion. So this is plantar flexion. So just ask the patient to point their foot towards the floor. So plantar flexion, okay? So here the patient again is lying supine. And then for dorsiflexion, we ask the patient to point their foot towards the ceiling. So that's dorsiflexion. Plantar flexion, dorsiflexion. And then we need to assess for inversion and eversion. So inversion is bending the heel inwards. So this is inversion. And this is eversion. So bending the knee outward. Again, plantar flexion, dorsiflexion, inversion, and eversion. After assessing the range of motion, we need to perform some of these special maneuvers for the ankles and the foot. So the first one is designed to evaluate the subtalar joint. So with this maneuver, we're just assessing the inversion and the eversion of the ankle. So what we need to do, you're not going to see again, we need to stabilize the ankle with one hand and grasp the heel with the other hand. And all that we're doing is we're like inverting and everting the heel. And then for the transverse tarsal joint, what we need to do is we need to again stabilize the ankle with one hand. We hold the forefoot with another hand, and we're just inverting and everting the forefoot. That's all that we're doing, inverting and everting the forefoot. And then for the metatarsal phalangeal joint, or the Mtp joint, what we need to do is we need to just move the proximal, so we just move the proximal phalanx of each toe up and down. And if there's any pain, then that suggests acute synovitis.